questions. Again, this is a table of pants and how they ask their questions. So, and you know, it's 6% is endocrinology. I've already tied my lectures to the pants. But again, what is the most likely diagnosis? How the clinical presentation is important for the pants and for eye test. How we manage them, whether it's preventatives, whether it's treatment, prescriptions, patient education. It's important, not just for me, but for the pants. Farm, I don't go too much into weeds. I go more in the weeds next block, but again, that's important. The one thing I probably don't really touch on is professional practice. Go ahead, yeah. Or maybe on or off. It says it's green. Wait, that means? Sorry. There we go. Ah! All right. I don't need to repeat it. You guys are good. Okay, thank you for catching me again. Okay, that's okay. All right. So then when it comes to endo, it's hard. It's a 2-block course. It's a very ology class. You guys you won't believe me, but you'll be fine. Again, the first test is typically harder than the second just because the topics, it's a lot of feedback loops, but don't overthink it. If the question seems straightforward, maybe you know it, right? So don't add too much to it. Read it fully, obviously. Avoid changing your answer. The studies show that's a good thing for test taking. And then this is an endo thing. If you get stuck and you're like, is it Cushing's, is it adrenal, is it testosterone? Wait, we haven't even talked about testosterone yet. Go back to your normal feedback, okay? And I'm going to tie that into the review with a whiteboard thing to help with probably the thing that gets most confusing is Cushing's and adrenal insufficiency. So again, going back to normal. What should normal look like? That can help with labs and diagnosis and also presentation, lots of things, okay? Here's a breakout of the test-ish. So most of my questions are going to be in section 4, which is the largest section. And these are ishes, right? So this will make sense when we go through it. But again, don't just study thyroid because it's a 2-block course, right? You need to study it all. All right. So lesson 1 was real short. Big thing on this, it's the smallest slide deck. Only a couple, I said what, 5-ish, 8-ish questions. Hormone classes, I don't make you memorize as I did in the past, but you need to understand the negative feedback loop. There's a lot of terminology in this, so you should know that. It's terminology I use throughout the entire block, but understanding the terminology. Alterations of endocrine function, it's a lot of words. What is that? So it's primary versus secondary. Now what does that mean? Alterations mean that something's wrong, right? It's abnormal, so we're talking about not normal feedback loop. We're talking about what? What's an example of an alteration related to primary?
Gland hypersecretion.
Yeah, so yeah, it's the hypersecretion or hyperfunction versus hypofunction, right? So with hyperfunction, there's primary, secondary, and ectopic. Ectopic is that out as a source outside the feedback loop that's causing what? Excess hormone, right? It's in the name, hyperfunction. Flip it completely, hypofunction, right? Is it a primary hypofunction like in primary hypothyroidism? Is it a secondary hypofunction like in adrenal insufficiency? Or is it resistance, where there's plenty of hormones, but the organs itself are resistant, like in posterior pituitary condition, diabetes insipidus, okay? It's the nephrogenic diabetes insipidus. Okay. So again, pretty light, but don't dismiss it, because these are easy ones to get right. Okay. That's it for section 1. Okay. So lesson 2 is all things posterior pituitary. What hormone do I care about? ADH, all day ADH, right? So if I've been saying no, if you get stuck, go back to normal. You should probably review what normal is, right? I kind of dive into the homeostasis review in these slides a little heavier than others because it's a relatively newer topic. It's a thyroid disease. But ADH is helpful. It's a helpful pressor, but do I care about that? No, I care just about the kidney stuff, right? So the V2 receptors, the osmoreceptors. What does ADH essentially do? Retains water, right? It's that anti-P, antidiuretic hormone. It's in the name. So if I don't talk about P, it might not be this one, right? Or urine, I should say. But again, understanding where it's activated from, right? The hypothalamus is where it's synthesized. It's stored in the posterior pituitary. If there's a change in serum osmolality, just a little bit, it is released. It releases through the bloodstream down to the kidneys, the distal collecting duct. As ADH goes up, aquaphorins come up. All that allows the water to come in. With water comes sodium. So I'm holding on to water and sodium. So my serum gets more dilute, but my urine gets more what? Concentrated and dark, right? And less frequent. So, and then homeostasis is reached. Now we have a balance. And again, increased serum osmolality does what to ADH? Increased osmolality, it's more concentrated, right? That's sodium. Yes. So if I have increased serum osmolality, we're going to increase ADH. And that's what happens normally for all of us. What are the disorders we talked about? SIADH and diabetes insipidus, right? So we'll go into SIADH first. Serum of inappropriate antidiuretic hormone. So it's in the name, right? Inappropriate secretion, right? Nobody asked ADH to come to the party, but it's inappropriate release, either from CNS disorder, medication, weirdly enough, a lung infection, right? Like a pneumonia or something can cause it. Surgery is a really common cause of this, right? So understanding those etiologies overall can help be like, oh, I know what, that this is SIADH, okay? So it's like, I think of the etiologies as a piece of the puzzle to get you to where you need to get. So again, etiologies, the good history will tell you. Acute versus chronic. Chronic is much more common. Acute is rare. It's that really sick patient with signs and symptoms. It's within less than 48 hours. But again, most commonly we're going to see chronic. So there's a lot more emphasis on that. Treatment depends on severity of symptoms. So if I told you most commonly this is chronic SIADH is what you're going to see. Do they come in and say, I think I have SIADH? No, right? It's found incidentally a lot of the time, right? It's like more progressive. The body gets used to this hyponatremic state. So you might not have some blaring signs and symptoms, but if they do, they're going to be neurologic in nature. So maybe like a little cognitive delay, potentially clumsy. But if they're having like headaches, seizures, then that's a little more scary. Okay. Is that ringing a bell from way back? Way back when. What are labs? Labs are going to be more important really than presentation. It's sometimes they're found incidentally. So we talked about osmolality, sodium, and P, right, urine. So what labs do we?
Urine osmolality.
Yeah, urine osmolality, plasma osmolality. I want a UA, right, to show that specific gravity. You guys already know it's going to be concentrated, right? So specific gravity will be reflect that. Same with the urine osmolality, really concentrated. Am I going to see a lot of glucose? I'm going to see protein. I'm going to see a UTI? No, right? It's just going to affect at least patients on the test will be simply just SIADH. What about the sodium? High or low? Yes, it's low, right? Because of the dilution due to that inappropriate release of ADH, right? So it's diluted. And they'll have varying, kind of how they present is likely associated with how low that sodium goes. Not always, but how low that goes. Treatment for this is going to be, if it's mild, it's just fluid restriction, which again, that can be really hard. So we all have our water bottles. If I have to restrict my fluids, that might not be easy for me, so then there's some medication that can help. So just understanding that. Now, what if they're stable and I give them some medication and fluid restrictions? That's fine. What about if they're not stable? What if they have neurologic symptoms? What do we do? So I have neurologic symptoms. You've already said I'm hyponatremic. I'm starting to have feel off, what do I do?
Slow drip.
Yeah, we're going to do hypertonic saline because again, this is mostly chronic. If it's rapid, we're going to give it to them fast. But if it's the chronic, then we're going to infuse them with the hypertonic saline, right? And then fix the underlying cause. Fix that lung cancer. Fix, because that's so easy, right? Fix that. Fix, give them some time post-op, or change their medications, right? If it's their opioids or their depression meds that are causing it. Okay. Again, what did I say? 10-ish% is in this block. So we got SIADH, and then the other one, also diabetes insipidus. What are the two types I care about?
Central.
Central and nephrogenic, right? They present so much the same, right? Exactly the same. How do they present? Polyuria, polydipsia, right? They're drinking a lot of water. They're peeing. They're peeing a lot. Do they come in always? No, right? Because sometimes they might come in, but then I'm drinking a lot of water, which is why I'm peeing a lot. So they might wait to come in until when? Until it starts to interfere with function, right? And if I'm not sleeping, or if I'm just sick of peeing all the time, they might come in and see you, okay? So they present the same. They have to have polyuria. So how do we assess that lab-wise? Yeah, our 24-hour urine. We need to see that volume. If they're inpatient, then you can monitor urine output. What other labs do we need? What? ADH. Yeah, we can totally just check the ADH here. What else? We're talking about urine. I probably want some of those same urine labs, right? That urine osmolality. I want a UA. I want a serum osmolality. I want a CMP. Well, if in SIADH, if they're hyponatremic, so in diabetes, does that mean they're hypernatremic? Yes, it depends, right? Like if I'm conscious and I have free access to water, I'm going to compensate. I'm going to drink water. So it could be normal, it could be hyponatremic, right? But the minute I lose consciousness or I lose the thirst center trigger, maybe I'm hiking, I don't have water, or I'm intubated, then you can get hypernatremia. Okay, so that one, the sodium varies quite a bit. But with SIADH, it's always low, right? Let's see. So if they present the exact same, the labs, sometimes that ADH can kind of help determine if it's central or nephrogenic. Same with the history, right? The history can kind of determine it. Well, what is that test, that confirmatory test? It was a long time ago. What's the other name for ADH? Vasopressin. So it's a vasopressin challenge test, right? And so, again, this is done inpatient there. If we're giving them synthetic ATH, so if I have nephrogenic central diabetes, where's the problem? Something's going on in my kidneys. They're resistant, right? Something, maybe a congenital thing, maybe a medication, I don't know, something that you will learn in a different class. Thankfully, I don't have to talk about nephrology, right? Okay, so we know it's something in the kidneys. And then you give me ACTH. Should my symptoms improve?
No.
Yeah, no, I shouldn't see a change, right? Because you can give me all the problem isn't in the pituitary, it's in the kidneys. Remember, the pituitary is working just fine. But if you give me ACTH and there's no change in my urine, no change in my thirst or my labs, then that confirms that it's most likely nephrogenic. Does that make sense? And then if it's central, what should happen? Yeah, you should see. I should pee a little bit less. I'm less thirsty, right? You should kind of get back to a normal because you're giving. The problem with central is something in the pituitary, right? You're finally giving me something that my pituitary isn't producing. Okay, good job. How do we treat this? Yeah, we give them what we're missing. Desmopressin, right? So I repeat, we give them what they're missing, right? We're going to give them ADH. You don't have to know this, but typically at night, once a night, nasally or different ways to give it. And they do pretty well. You gotta monitor them though, right? And give them a lot of education, things like that. Okay, feel good about only one hormone, hey, only 2-ish, kind of 3-ish conditions. Very unique versus the other ones. Okay, lesson 3. Lesson 3 was like, I'll just throw a lot of anterior pituitary at you. a lot. We talked about a bunch of different axes. Again, the HPA, the hypothalamic pituitary, anterior pituitary axis. This, knowing what normal is, helps a lot. This is where I introduced the cross-reacting hormones, right? So when prolactin is high, it inhibits LH, why we see that in the signs and symptoms. Sometimes if the thyroid releasing hormone is high, it can also cause excess prolactin. So we have to rule that out anytime we have somebody with high prolactin. And then the growth hormone and thyroid connection, which is pretty generalized. But what happens when ACTH goes high? Say in like primary adrenal insufficiency. ACTH is high, there's this hyperpigmentation from the MSH, right? Melanocyte stimulating hormone. So again, just review those, but again, you'll see the top three as you study anyway. So it's not like a pointed question, it just helps you understand and get to the diagnosis of your treatment. I talked a lot about adenomas, like the majority of adenomas there's a bunch, but I talked about 3 that release hormones, and then the non-functioning, which usually affects males, right? And they're going to be, if it's non-functioning, am I going to come in complaining of things? No, not until it gets bigger. And as it gets bigger, it's going to cause a space-affecting side effects where I get a headache, I get vision changes, right? Peripheral vision changes, and things like that. Overall, we did talk, what's the imaging for adenomas? MRI, right? No problem. What's the treatment for adenomas? Understand that, right? It's varies versus non-functioning versus the other 3 that you talked about. Okay, before we go into each adenoma, causes of hypopituitarism. So what does that mean? Hypopituitarism. Yeah, it's something. There's something. It's a primary hypofunction, right? Something disrupted the pituitary from working. So if the pituitary isn't working, whether it's one or multiple hormones, it's going to impact homeostasis, right? Because this is the pituitary is that master gland that leads things. Okay, so don't forget about that. And then just recognizing the life-threatening hormone deficiency. What we talked about? A couple of these. But what comes to your mind when I say life-threatening hormone deficiency? Cortisol, right? Adrenal crisis. That's what we care about in pituitary apoplexy, right? Pituitary apoplexy, where there's a hemorrhage or infarction in the pituitary, so it fails. That's the hormone we care about. And then you have a mixed edema crisis, where it's the severe hypothyroidism. It's not from the pituitary, but that's another example of a life-threatening hormone deficiency, just from a different cause. All right, and understanding how to treat that. Labs are different when it's hypopituitarism, patient education, all that stuff. Okay. Real quick. I don't know if I have it on the slide, but there's a few conditions you just have to be able to recognize because they're like one slide. So it's like growth hormone deficiency has a few slides. You should probably understand that. Sheehan syndrome, that's pretty unique, right? TBI, right? Those neuroendocrine disorders, because there's people who have TBIs and they don't get better, right? They might have an endocrine issue. So that's towards the end of the slides, but just being able to recognize that. But this is fair game. Lots of things. So galactotropic adenoma, prolactin is the problem, right? Making sure you know what prolactin. If you know what prolactin does normally, I'm focusing on the disorder, right? But again, understanding normal helps you realize like something's not right. And again, it's excess prolactin from an adenoma, okay, in the pituitary. So very classic features. We've gone through this in our check on learning. We've gone through it in our cases at the end of lectures. When I first teach it, you guys kill it on those cases and stuff. But again, very classic presentation. So understanding that. With the labs, what labs do you do? Kind of guess with the prolactinoma. Yeah, prolactin. What do I need to rule out? If it's a female pregnancy, if it's anybody, male or female, what do I need to rule out? TSH, right? Is there a hypopituitarism because of that TRH, right? So this one has 2 of those cross-reacting HPA hormone things. So again, it's really important. What imaging? I do my history, my physical. I do my labs. Where do I take my pictures? Right? Yeah, it's pituitary adenoma. And then know how to treat it. Okay? If it's a prolactinoma, how do I treat it? Most of the time.
Dopamines.
It's the book answer.
Take it out.
Prescription, right? Know the prescription. Prolactinoma prescription. Dopamine agonists, okay? Understand that. If it's a thyroid disease, should I throw dopamine at it, or should I treat the thyroid condition? Probably not, right? We're going to treat the underlying condition first, treat the thyroid. That's really the special factors. Okay. Somatotrophic. This one, I think you guys do pretty well on this as long as you read the full question, because again, it's excess growth hormone, but they have a very classic presentation, right? I think prolactinomas are pretty classic, but it's probably because I teach it 3 times a year. But again, but I would say prolactinomas are more common than this guy. But again, very classic presentations with the large hands, the facial changes. Don't forget about the internal organ changes, right? They're at risk for a lot of things. So that's the second slide, so understanding both of those. Because that is important, because you're not the one doing the surgery, but you're the one managing these people and their screenings, because you're going to catch the diagnosis, okay? Remember, this is a gradual thing. It's not overnight. What labs do we do? So the problems in adenoma kicking out excess growth hormone, what labs should we check?
Yeah.
Remember, IGF-1, right? And if we really want to get fancy, when we're worried about it, we can do that. Or a glucose challenge test, right? If in a hyperglycemic state, cortisol should be decreased. So we make them hyperglycemic. They expect cortisol to go down, and it's high, right? And that's because of this adenoma. Sure, we already know MRI. How do we treat this? Surgery. What surgery? Transmural resection, right? Yeah, that fun in your nose. Dr. Cushing mastered that for us. And then what's the key difference with gigantism? Yeah, age, right? The growth plates have not fused yet. They're still growing. And yeah. Questions on that? Same exact thing with corticotropic adenoma. We're going to talk about this in detail with the whiteboard drawing and stuff. But again, ACTH secreting adenoma, Cushing disease, ACTH dependent, all in the dome, right? ACTH is driving the problem, which is essentially high cortisol, right? Hypercortisolism. And very similar, right? The clinical presentations. How do these guys present? Real classic, right? The old man in his little chonies. Sorry, underwear. So yeah, in his underwear and with that one, it's really important. Cortisol's okay, but when it's in excess, it causes a lot of problems, right? What kind of problems are we talking about? Yeah, skin breakdown, right? Ecchymosis. We use cortisol though, right? We use it why? Because it suppresses the immune system. So we want to do that sometimes. Also, it's anti-inflammatory. Sometimes we need that for our asthma patients and things like that. So we know that. But again, long-term, unregulated cortisol excess is a problem. Hypertension, it's correlated with diabetes, obesity, osteoporosis, right? It interferes with the integrity of the bones, and then again, that's central obesity, and all the other things that go with that. This is important, just like what labs do we do? Cortisol's high. Dexamethasone suppression test. What else? 24-hour urine or the late-night salivary, right? What is unique about cortisol, or ACTH and cortisol and growth hormone as far as the release? How is cortisol and ACTH released? Pulsatile, but more specifically with cortisol, it's what? Diurnal, right? Think of how the kids' symptoms get worse. We all kind of feel a little more lousy at night, right? Since the diurnal, as that cortisol decreases, our immune system picks up the fever goes wild, right? With growth hormone, that's pulsatile, and it's pulsatile through various things make both of these get released. But again, pulsatile is the growth hormone, and the diurnal is classic ACTH. We know the RADs. Oh, okay, so if I have dexamethasone suppression test and I do my urine and it's high, sweet, can I say they have Cushing's disease? No, it just says they have high cortisol, so what lab helps to tell me where's the problem? Yeah, so ACTH. ACTH will tell me where the problem is. Corticotropin, this is why Cushing's and cortisol gets confusing, is because there's overlap, but we'll figure, it'll all come together too. Well, by Friday, right? So we do ACTH points the direction, and then that tells us what labs, or what RADs to do, excuse me. Should I look at the brain or should I look at the animals? If it's ACTH dependent, where should I focus my, yeah, here. And when we get to lesson 5, we're gonna do a diagram and we'll talk more about the labs, okay? Special factors, how do we treat this? Med, surgery, or radiation? Surgery, yep, you should know that. And then what happened and what to do post-op too. I'm not going to go through this, but again, these slides can help you. If you're stuck, talk yourself through this. This is what normal, and this is, with this, it's an adenoma, so it doesn't behave normally, right? Cortisol's high. And then here, this slide is helpful. Okay, that's it for anterior. Decent amount of questions. It's like the second most, I can't remember my ish range, but it's at least it's like very, like they're very unique. And there's overlap with how you study and should be. All right, thyroid is the 4th lesson. It's the most 30 to 35% of the questions are on the thyroid gland. It's the most common thing that I talk about this whole class. I talked about it for multiple days. You guys should all know the feedback loop by now, right? It was the first example of feedback loop I taught on day 1 before we went into this. You've learned about thyroid, A&P, pathology, cup farm, obviously. So again, just knowing what normal is. And then also knowing how to explain that to your patient because they can get confused too. So, understand labs, imaging. We learned about ultrasound, we learned about radioactive scans, we learned about fine needle aspiration biopsy, and so understanding when to use those. And you learn all that through the lesson. Hyper and hypo, how do they present? Very differently, right? What's hypo? Turn the knob down, thyroid hormone, metabolic stuff goes down. Know what that is. Opposite for hyper, right? Understand how they present very differently. They both can have fatigue. They both can have menstrual cycles. They're both tired. They're still tired. Their weight changes. Hypertension, right? So I have to paint a picture for you. If I'm going to ask you to tell me how they present, or if I'm going to describe a patient that has one of these. Okay. Workup. What labs? TSH. Add a free T4. When do I order a T3? It's great. So that hyper, that tachycardia, that type of presentation. If I'm working someone up, say for a PIA, right, I'm going to throw in all of the labs. Okay, good. And then obviously you can do the antibody panels and stuff like that, but I don't make you go into the weeds on those. Do I need to do a thyroid ultrasound to diagnose hypothyroidism or hyper? You don't, right? If they have a goiter, I'm going to use all the tools that I can, but you don't need imaging to make the diagnosis. It's what? It's the labs and the signs and symptoms, right? Understand how you treat both. Definitive treatment for hyperthyroidism is in there multiple times, but you still have to know the medications, right? Not everybody's going to have definitive because they're pregnant or various reasons. You got to understand both and all the nuances of levothyroxine. But they're not going to make you dose it. Questions? Thyroiditis was a totally new topic, or maybe, and it encompasses, remember, that group of disorders related to inflammation of the thyroid gland, sometimes enlargement. But again, if Graves' disease, it's that autoimmune where the receptors go crazy and you have a thyroid party, excess T4, excess T3, you feel lousy. With these ones, it's just a passive release of the hormones, okay? So again, it's not that hyper, it's that variable hyperthyroid state. As that passive release decreases, you get this euthyroid into hypothyroid. Okay, and they present differently, right? Like, I mean, it's in the name, postpartum, right? We talk about other pregnancy stuff too, so don't just automatically, if the patient's pregnant, pick that, read the whole question. Painful, subacute, and infectious, understand how those are different, right? Viral versus bacterial, how they present is very different. How you treat them is very different. And so again, understanding that. What's the most common? Out of all of them. The Hashimoto's, right? Hashimoto's, which leads to hypothyroidism, right? And for Hashimoto's, they typically they're going to be on Synthroid forever, versus these usually get better. I remember the IgG4 Rydell's is that fibrous, where that you get the scar tissue, the hard. You'll have radiating pain and stuff like that because the fibrous tissue causes pain. Okay. I think there's a table. Do I have the table here? No, there's a table in there. If you have questions or it's not clicking, you guys can text or call me. I'm TDY this week. I'm coming back to help teach a PEDS lab on Thursday. I think my TDY should end at 11. So I'll be around, but you just shoot me a message if you have questions, okay? And I can do like a phone, so I won't be in my office and find you and review like my phone or something too. Okay. Goiters. So this, you kind of know with goiters, you understand why the pathophys, why you see them in hyper and hypo. And we do the ultrasound, right? Or maybe the scan. You also, through this lecture, we understand kind of, I'm not going to be like, here's a scan, what's the diagnosis, but I'm going to help you. Now, hopefully, if you think of the pathophysiology, the scans will be easier to understand, and so it'll be a piece of the puzzle if I throw it on there. Nodules, understand what you do when someone has nodule. You will see this, or Women's Health will see this and boot them to you, okay? So understand the steps. The thyroid nodule and the thyroid cancer kind of overlap, right? But again, what's the 3 steps? Examine, is give, you guys have, all of you have a thyroid nodule. Now, what am I supposed to do? Single thyroid nodule. What is the first step? Let's do some labs, and then the labs can help direct me. I'm probably going to do an ultrasound regardless too, but the labs tell me, do I need to do a scan too? So it's like a simple like flow chart, helpful. Does everybody get an FNA biopsy? No, you should probably understand that, right? And then ultimately, we're trying to, that helps us understand cancer. There's 4 different types of cancer. Medullary thyroid cancer ties to those MEN conditions. Understanding the treatment of thyroid cancer is important too. We'll see it. You'll have patients with thyroid cancer. And then lastly, our emergencies. What are our emergencies? Whoopsies, did I say? Sorry. The knob goes real extreme, right? So real low, what is it? Mixed edema, real high, it's a storm, right? Too much hormone, too much rain, too much lighting, and all that. So we have the thyroid storm and mixed edema crisis. These guys are sick, right? These are your sick patients. The treatment overlaps, but it's different, right? They're going to the ICU. They don't all make it. So again, understanding the treatment and recognizing it is important. Okay. Luckily, it overlaps with what you already know, just extreme versions. Oh, I was in the wrong slide. I'm like, that's not right. Sorry, guys. I don't know. I'm crazy. Let me just make sure I don't have anything else. Okay, how do you treat? Does anybody remember how you treat mixed edema crisis?
Steroids.
Yeah. Yeah, we need to give them levothyroxine, right? Like mixed edema, I understand the precipitating causes, right? Like I'm a little lady who forgot my meds, I had surgery, or I don't know, various things. I'm not taking my levothyroxine, and then I get sick, or if there's stress to the body, regardless, I go super low. I am giving them. Are you managing this mixed edema crisis? The little lady with the frosy hair? Did I say that right? Frozy? No. Anyway, are you treating her? No. They're going to the ICU. Okay, next, thyroid storm, right? Graves' disease on steroids. No, just Graves' disease with extreme, right? It's an emergency. They're having arrhythmias, they're sweating, they're febrile, they are not doing good. Now how do I treat those? So we need to, they're tacky, they're hypertension. When do I give them iodine?
An hour after.
After, right? We need to reduce the synthesis through what? How do I decrease this? The problem is too much hormone. You just go like, thyroid storm, too much hormone. I treat that with an antithyroid, right? PTU is ideal, but I'm going to treat them with to decrease synthesis, right? And the conversion of T4 to T3, right? And then iodine, if I give them iodine, that activates the thyroid, right? We want to calm it down first before we do that. That's fine. I hate like do this before this, but that one's okay. Don't want to give iodine, so you have to know. All right, questions on thyroid? Feel good? Okay. Maybe. Maybe I'll ask you on Thursday. Okay. So this is where we'll go onto the whiteboard if you guys want. But again, you know it's the ACTH is released from the pituitary, it goes to the adrenals, and the adrenals do what? Release the primary hormone is cortisol, but androgens are affected, and then aldosterone too, just a little bit. So we'll go into this. But again, excess cortisol, ACTH independent. So that means it's independent of ACTH. You have high cortisol. Why? There's some problem where? Where's the problem? Independent. It's in the adrenals, right? It's not the ACTH from the pituitary causing the problem, it's the adrenals. So we'll go over how you'll get there on your own. How do they present? How does my Cushing syndrome patient present? Same as Cushing disease or different? Exactly the same, right? So again, that tells me I need to know my labs. Luckily, it's the same initial labs, and the ACTH is the same, right? All of that is the same. The imaging are going to be a little bit different. If I think I have ACTH independent, where do I get the pictures?
Abdomen.
Yeah, I want to look at if I think the problem is primary, I'm going to look at a CT. How do I treat them?
Take it out.
Right, take it out. What are the two causes it could be? Yeah, so it could be an adenoma in the adrenals causing excess cortisol, or it could be hyperplasia. Okay. Same with the causes of aldosterone, only with hyperaldosteronism, that adenoma is kicking out excess aldosterone. In Cushing's syndrome or ACTH independent, it's pushing out excess cortisol. Okay. I'll draw a picture if that helps you. Again, this is a very helpful slide. I don't recommend memorizing it because I'm old, but again, if you follow the slides, if this diagram that we do makes sense, you hopefully won't have to memorize it. But then again, understanding the treatment of all of them. There's a table directly from your slides, or so I think I told you to start this, but obviously it's all there on one little page. It should make sense, right? So like exogenous steroid use, let's taper you off. ACTH adenoma, we already know this, the transcriminal resection. Ectopic secreting tumor. We're going to talk about that in just a minute, but what is that? Ectopic ACTH dependent secreting tumor. Where's that probably going to be? Somewhere else, not in here, so where do you think? Pick an organ. The lungs, yeah. Technically, it would be anywhere, but usually a lung cancer will cause that. And those tumors, those malignant tumors, they don't play nice, and then they can cause problems with either SIADH or excess ACTH. And then here's the, where it's the primary, or the adrenals the problem, right? Bilateral hyperplasia. We're going to try to do medication first. And I didn't really go into details on the meds. But if it's an adenoma, we're going to do the surgery. And then, of course, regardless of what we do, we need to give them steroids because if we surgically remove anything, their steroids can tank, and then we give them withdrawal syndrome. So we want to avoid that. Okay, we can take a break, or I can keep going as you feel like it's 42. Yeah, we're going to just charge. Okay, so this is, if you want, this is on your slides. I'm just doing all the animation. I just don't want to go too fast. Okay. I'm trying to decide. So there's like a whiteboard that's easier because I can't draw on this because these things don't work. So I'm going to do the whiteboard. But, so if you want to move, or I think, what do you guys, can you see if I put it in front of the camera? Okay. see, will she take out the board? Will she take out the screen? That is the question. Yay! Okay. All right. So, is this good? Oh, I don't
That's
want
good.
the camera. Ooh. Okay, how about that? I'm going to begin anyway, I guess. So, I'm going to turn off this screen. Can I just, how do I do that? I'm just going to, okay.
Here,
here's my
just push
text.
that.
Just do that. Okay, so you have this screen. Okay, so we have, you know those people, those osmosis people who do like the pretty little art? Remember, we're in Colonel Heater's class, so expectations are much lower. I am not an artist. Okay, so signs and symptoms of excess cortisol, right? You know those. Know those. Know your initial labs. I'm not going to talk about those, right? Know those. So right now, based on your awesome history and your physical exam, right, you actually looked at the patient and listened to them, we think they have high cortisol. So before we go to the ACTH to point to the problem, the first cause is going to be, there's an adenoma. Pituitary adenoma. What does ACTH do? It's high, right? And then that exit, if there's high ACTH, what does that ultimately do to cortisol? High, right? The feedback loop is there, but what the problem is here. So if I do my lab, and we're saying it's a plasma ACTH, is your lab, what is it going to be? What's it going to be in Cushing disease? Is it high or low? High, right? So we have high ACTH. You can memorize this, or you can You know, a lot of times I'm like, point to the problem. So the other thing, if you don't want to draw this out, you can go back to your normal feedback loop. So you would go, if I tell you you have a patient who has hypercortisolism, and I tell you the lab, it's elevated ACTH, and I say, where's the problem? What's the diagnosis? Then think. So if I say, let me say that again. So you have a patient who has high cortisolism, and I tell you their ACTH is high. What's the diagnosis? So then, how do we get there? You could draw it out, which is great, or you could be like, what happens normally when ACTH is high? Is you have high, where's the problem? What should the pituitary do if cortisol is high? It should decrease, but it's not. So the problem is the pituitary. Does that make sense? Okay, so we know they have high cortisol. ACTH should be low normally, but it's not, indicating that it's a pituitary problem. Okay, so then you get an MRI. You're like, I got it, it's Cushing disease. And the MRI is normal. Now you have your ectopic cause, right? And this cancer causes a problem. A lot of, I don't think you know this, but a lot of ACTH, therefore a lot of cortisol, right? So again, if I do the MRI or I tell you they have like a history of lung cancer, this is why, does it make sense why the ACTH is high? Right, ACTH dependent, okay? So again, this. So now, you have an adenoma on your adrenals, or you have adrenal hyperplasia, right? So excess activity. The whole gland gets bigger and it's more active. So this is producing excess cortisol. What does the pituitary do when excess cortisol?
Shuts it off.
But they still present with that positive, the high dexamethasone suppression test, the high 24-hour urine, the signs and symptoms of high cortisol. So then if I do my plasma ACTH, what should it be? Low. So you can use this diagram to go back and forth, right? So if I paint a picture, if I say this person has adrenal hyperplasia, what's the lab? What lab do you expect? Got it, right? Or the opposite. I give you the lab and then I ask the diagnosis. You guys feel kind of familiar with that? Okay.
Ma'am, how significant of an increase is the ACTH for the ectopic in the lung? Like, is it very significant?
Yeah, but I don't think you know the difference. Typically, yes, but no, it's not 100%
we don't have to
across
know.
the board.
Okay.
Just know it's high. And so remember, 90% of the time, it's going, actually, 90% of the time, it's going to be the adenoma. 10% of the time, it's that. So again, if I have a high person with high cortisol, and I'm on the test, and I'm like, okay, sweet, she told me this person has high cortisol, I'm good. And then she's like, the ACTH is low, what's the diagnosis? Or the ACTH is high, what's the diagnosis? You can figure it out by either drawing it or going back to the feedback loop. What should happen normally, right? Normally, the pituitary should decrease ACTH, and it did. So then the problem's not the pituitary. Or normally, the ACTH should decrease, and it's not. So the problem is what? Pituitary. Okay. You can do this exact same thing with adrenal insufficiency. Usually, you guys get this better. I won't draw it out in class unless you guys want me to for adrenal insufficiency. I'm happy to. But yeah, there we go. That's your elementary, or like, not even, I think my elementary son can draw better than that. Let me go back to the slide, and then so in your slide, I have a blank one. And I realize now I forgot. What did I forget? Exogenous, right? The most common cause is us treating it, right? So exogenous steroid, shoot. So what do I expect labs if they have exogenous steroid use is causing your problem? So I'm getting back injections. What was that actress, the comedian's name? Amy Schumer, right? She got Cushing's from her injections. So the injections are causing cortisol to be high. What does the pituitary do? Well, first, would that be secondary or primary? Sorry. Hold it together. It won't work now. Is it working on you guys too? Okay. All right. So you can do this yourself with the blank. The next one is all filled out, but again, signs exactly clinical signs and symptoms equal cortisol. How ACTH points to the direction or where the problem is, and then if you get stuck, use the normal feedback loop. Okay. So here, oh look, I know you can't do animations if you have to pee, but this is everything we just did. Okay. So prescription trigger. Cortisol is high. ACTH is going to be low because it's not a pituitary problem, right? It's a prescription problem. Okay. And then here's your adrenal. I think the adrenal ones can be the most confusing because it overlaps with hyperaldosteronism, but just think of it as it's just excess, and one is excess cortisol, one is excess aldosterone. Okay, so that's everything we did on the whiteboard for you. There. And then, oh look, that's how he presents. Not adrenal insufficiency, right? Okay. And then, okay, adrenal insufficiency. How did these guys present? Hyperpigmentation, right? This is primary. Primary adrenal insufficiency, where's the problem? Right? Yeah. Adrenals. And what causes it? Is it infection? What is it? Autoimmune disorder, right? They atrophy and it's a slow progressing, or sometimes they present as an adrenal crisis, right? But hyperpigmentation, what else? What are their vitals like? Yeah, they're hypertensive, they're fatigued because it's endo, maybe some weight changes. Non-specific though, they could have like just some GI stuff, and you're like, oh, okay, make a food diary, and eat more fiber, right? But they don't get better. Nauseous. So again, understand how these present differently than Cushing's. And in the lab, so what's the underlying problem with adrenal insufficiency? Not making enough cortisol, right? Whether it's a secondary or primary problem, not making enough cortisol. So now knowing that, what lab should I check? Cortisol. And we're going to do the plasma ACTH. So again, we're going to just go straight for the labs when it's low. And what lab helps determine where I do imaging? Just like Cushing's. ACTH. The cortisol confirms it's low, but ACTH points to the direction. So we'll do another flow chart, and then you got to understand treatment. How do I treat these patients? Yeah, we're going to replace them with steroids, especially with Addison's. Do they get steroids just for 6 months and have a nice day? No, this is forever, right? The sick day guidance, all of that stuff. So understanding all of that is important. Keep pushing. Okay. All right, so secondary. This is where it gets a little funky. But right away, the easiest, the most obvious cause would be a pituitary issue, right? If there's some kind of pituitary damage to the pituitary, and if we have less ACTH, we're essentially going to have less cortisol, right? But what's the most common cause? It's medication, right? So if a person who's taking chronic daily glucocorticoids, they're like, oh crap, this is bad for me. I am going to stop, and I'm going to stop abruptly. Oh, that's not good, right? Because we're talking endocrine, it's not fast like neurology, right? So it's going to take a long time for my pituitary has been suppressed, my adrenals have been suppressed. Does that make sense? They've both been suppressed. Why? Because I'm taking cortisol. I don't need to work. They get to take a little rest. And it takes anywhere from 6 to 12 months for that access to work again. Okay. What's that confirmatory test? Cosinotropin. I don't go too much in the weeds in that, but just know it exists, and it's essentially low in both, right? It's if I'm giving someone synthetic ACTH, but their adrenals don't work, it's gonna stay low, right? Does that make sense? So here's I'm gonna give you ACTH. Adrenals, no matter how much ACTH you give them, they're atrophied. Someone who had meds, yes, their adrenals work, but they've been suppressed. So maybe 6 months down the road, you'll see changes in the cosinotropin, okay? But I don't get in the weeds because we're not going to order them. Just know it's a confirmatory test. Okay. How do the presentation of secondary differ than primary? Yeah, the alabaster skin. Electrolytes are going to be different too, right? So when you're Addison's, which one has primary, secondary? Which one has abnormal electrolytes? Let's guess. 50-50. Yeah, it's primary. Hypoglycemic, hyponatremic, all of that stuff, the hyperpigmentation. And then again, it's all about the ACTH, right? Here's the slide, ACTH. We'll point to the direction. If when you study, you get to this and this doesn't make sense, why it's elevated here and low there, let me know. Work on it. The next slide can help you too. Talk it out, teach it to somebody else, and that will help too. I'm going back a slide real quick. Just don't forget about adrenal crisis or acute adrenal insufficiency. Remember, these people can present like that, or they can show up like that with sick days. Okay, sorry. So again, Addison's patient can present like that. Remember that man who came in with Addison's to the ER with chronic kidney disease and hypertension? He had Addison's, and he showed up in the ER and he was sick. How do we treat adrenal crisis? Steroids right away, right? Understand the specifics of the treatment, okay? Not only treatment, but you got to be able to recognize it. Okay, so this is a nice money slide for adrenal insufficiency. So again, you have your primary and your secondary. So we already know the clinical signs and symptoms. We already know the labs, right? A low cortisol in the morning. Why in the morning? Urinal, right? We expect it to be highest in the morning, and it's not. And then we do that morning plasma ACTH, and it's going to point to the problem. So again, it could be secondary. Sorry, we'll start through primary with adrenal, autoimmune adrenal atrophy and failure of the cortices, or secondary, a pituitary problem or prescriptions that was immediately stopped, okay, without a taper. So let's go through this on here. So autoimmune failure, we know it's primary. Oh, they got real small. They're not working. So they have those classic signs and symptoms. If we do the ACTH, they have low cortisol, and what do you think the ACTH is going to be in primary? High. Why? Yeah, the pituitary is working, right? That tells me the pituitary is working if it's an adrenal problem, okay? Or you can draw out the feedback loop. Pituitary, it's a normal pituitary response to the low cortisol is an adrenal problem. Sudden discontinuation of chronic glucocorticoid steroids. So, oh no, These are bad. I'm going to stop them. Why is the ACTH low here? Yeah, it's been suppressed, right? It takes a while for it to work out. Okay, what is it going to be if they have secondary adrenal deficiency due to pituitary HPA, some kind of trauma surgery? What's ACTH? Low or high? It's low, right? Because this, if it's low, where's the problem? In the brain, right? Because the cortisol is low because the pituitary isn't signaling it to turn on and work, okay? Where's the problem? When cortisol is low, ACTH should what? Increase, and it's not, indicating that it's a pituitary problem. Okay, so different ways to think about it. And then this is not a Cushing's lady, right? She's skinny, she's hyperpigmented, she's hypotensive, she has GI symptoms. Don't get that confused, okay? Questions on that? Okay. All right, any questions on that? You sure you don't need a break? You probably have like 10 more minutes, so. Okay, hyperaldosteronism. All right. This one you guys do pretty well on. How do they present? Yeah, they're hypertensive. Why? Yeah, that access, yeah. What drives aldosterone? What feedback loop? ACTH plays a role with the RAS, right? Right. So yeah, renin, angiotensin 2. Renin goes up, angiotensin 2 goes up and does its thing all over the body, and then ultimately aldosterone goes up. Okay. But it's a problem if it's going up all the time, right? This is independent of the RAS. Independent of the RAS. So it's a problem. And so they present. Understand how that hypertension is different than essential hypertension, right? All the factors. What labs do we do? Or before we do that, or they come in and say, I think I have hyperaldosteronism? They don't. They just have this non-classic hypertension, whether it's they're young, family history, refractory, on lots of meds, etc. Okay, now what labs do we do? Urine, UA, so you can check your urine, see if there's like protein or something else. What else? What drives it again? Do I do an ACTH? No, because that's what, yeah, so then what's that lab? PRA, right? Yeah, so if the PRA, the renin lab is, what do we expect it to be? If aldosterone's high, what should renin be? Low, so PRA is going to probably be low, right? Should I check an aldosterone? What will that be? High. And then we get to the confirmatory, which is you can consider a 24-hour urine aldosterone, okay? Treatment, before we treatment, where do we do images? Adrenals, right? Because what do we expect to find on imaging? Two things it could be. Hyperplasia. Or an adenoma, right? It's the same as Cushing's syndrome or ACTH independent, right? It's the adenoma or the hyperplasia. And so guess what? You have to know how to treat those. If you had to guess, how do you treat an adenoma? That's kicking up excess aldosterone.
Chop that.
An adenoma, we want to remove it. Okay, what about bilateral hyperplasia? Spironolactone, right? Why? Because it has that it's a potassium-sparing diuretic, but it blocks the secretion of aldosterone. Okay, super important. What does happen? Men don't like spironolactone. Yeah, gynecomastia, libido, and things like that. But okay. All right. What is congenital adrenal hyperplasia? What are the three things I need you to know? What do you think? What do I always want you to be able to just recognize it? Is this happening to a girl or boy? Or female or male? You'll probably know that. Okay. Okay, female, male. You got 50-50 shot.
Female, you said.
Female! There we go. Yeah. So, again, what's the problem? It's in the name. Congenital adrenal hyperplasia. So the adrenals are excess. And we're talking about puberty stuff, so what's in excess? potentially excess androgen. And they're going to have low cortisol because of an enzyme deficit. Okay, what's that enzyme? You should know that. What lab do we do? You should know that, right? I'm always 17, never 21. The Taylor Swift song that does not exist. I don't know why that helped me remember. But again, and then be able to recognize it. Okay? 3 potential things I could ask. All right. Okay. Lesson 6. We're almost there. So this one is a fun one. We talked about our pheo, which I know you learned about in pathology. This is where the sympathetic nervous system comes in, that fight or flight, right? It's another stress-triggered feedback loop like cortisol, but it's quick. And what hormones are we talking about? Norepinephrine, epi, right? Awesome. And are they low or high in a pheo? High, right? We have a pheo is excess catecholamines, excess norepi or epi causing problems. How do they present? Very classic presentation. Increases, sweating, tachycardia, right? Hypertension over 80%, 81%, but it's high. And anxious, right? Restless. What is unique? Another trigger that it's pheo. Paroxysmal, right? It's episodic, right? Triggered by the IV sedation, medication, from decongestants to cocaine, right? To ADHD meds, right? All these things, bending forward, working out, all these things can trigger it. But they could also just have chronic hypertension that you can't control. All right. What labs do? We do all the labs, right? All the labs. If you have someone with hypertension, palpitations, anxiety, tachycardia, diaphoresis, we're going to do all the labs. But what is the money lab? Catecholamines, free plasma catecholamines, right? That's going to be higher level. Okay. Imaging, what do I do? Where do I do this? I tricked one of you guys during the cases. Where do I do my imaging? Yeah. I want to do non-contrast. In real life, you might see contrast. And in real life, some people miss a pheo, but you won't want to. Be ready for it. Because it's Friday, and you know it's ENDO. Okay, so you non-contrast CT. How do we treat it? Should you just leave it, monitor them? No. Good idea. So how do we treat this? Surgery. What do we do before surgery? Really specific hypertension control, right? Really specific. Yeah, A and C before B, right? That alpha blockade. Review that slide. You're like, did you guys cover that in farm? No, just thyroid. Diabetes? ENDO. All right. MEMs, remember, I'm going to come back to MEMs. We'll come right back. Because if I don't, I'll skip adrenal incidental-lomas. What's that? Incidental adrenal. Understanding. You're going to do an adrenal and pituitary workup because why? It's in the adrenals. So those two go together in ENDO. It can be secreting excess cortisol. It can be secreting excess aldosterone, or it could be normal. Understand when you do monitor or when you do surgery. Does anyone remember? 4 centimeters of size. Yeah, or if it's small and they're really young and I tell you it's bad, but yeah, it's really 4 centimeters. And then understanding when you monitor and how you monitor. Okay. Secondary hypertension is that towards the end it was just like a hodgepodge. We just talked about hypertension a lot, right? Cushing's, hyperaldosteronism, pheo, thyroid disorders. Hyperparathyroidism is coming. But we talked about it a lot. So, MENs, how many are there? How many test questions? So you could be like, -1. I don't have enough in my brain. Or, I do -1 for like heme, because it's like 3% of the pants. So I'm like, oh, -3%. No, you guys are doing better at heme than me. I guess I did okay. But I just don't feel confident. Or, instead of -1, it's like 1 point something, right? How much is each test question?
2 points.
Oh, so no, not -2. Try, at least shoot for this, right? So again, medullary thyroid cancer is 2 and 3. We have the 3 M's, remember, the mucosal neuromas, medullary thyroid cancer, or the Marfan's, that's 3. Well, if it doesn't have that and it has medullary thyroid cancer, it's automatically 2. And then these 2 are really similar with all the P's, parathyroid, pancreatic adenomas, pituitary adenomas, parathyroid, I already said that. But what's different? The cancers and the I don't like numbers. You guys got it. That's so bad. Oregon -2. Don't go for it. If it sounds like an MEN and it's everything about it sounds like an MEN, don't pick a non-MEN that I haven't talked about. All right. Any questions on that? That's the review. If you don't understand, usually adrenal insufficiency or Cushing's, where you're like, crap, I know adenoma when it's Cushing's, but I can't remember what to do when it's hyperaldosteronism, just let me know. I'll say that if you have questions. You want to go through feedback loops for insufficiency. I'll give you a marker. You can teach it. No, we can go through it. Okay.
I hunkered down for
And then my phone number is somewhere. It's on the